7 o'clock, and great pleasure in welcoming Prathapan, Dr.Paari, Dr.Ilango, Dr. Subramaniam, and others to this new session coming from Calicut. And over to Prathapan.
Good evening, Patta sir, my dear friends, Dr. Ilango, Dr.Paari, Vijayaraghavan, Dr.Sankar Subramaniam, my dear students. First of all, I thank Dr. Patta sir for giving me this opportunity to present these clinics of surgical gastroenterology from Calicut. So today we will be discussing an interesting case of chronic biliary obstruction. So there is some interesting thing in the case, as well as we can have discussion in between. So I will go straight to the case. So the case is of a 36-year-old female. She was symptomatic since 18 months when she attended to surgical gastroenterology department.
But you have slides, Prathapan, you have slides. You can share the slides if you have.
Oh, I have not shared the slide. Okay, right, sir. Now, can you see this?
Yeah, you can. You can make it full screen. We can see. Yes.
Okay.
Wonderful.
So the patient is a 36-year-old female. She was symptomatic since 18 months. Initially presented to a local physician with fever of unknown origin, and she was diagnosed to have features of cholangitis, and she was referred to a gastroenterologist in Mangalore, and further workup were done by the gastroenterologist. So he investigated, he diagnosed to have features of biliary obstruction due to multiple lymph nodes compressing the bile duct. Largest lymph node in the proximal part of CBD of size around 4 into 3 centimeter with areas of necrosis. So he did a Mandos test that was weakly positive. At that time, endoscopic ultrasound was not available. So he decided to do a CT guided FNAC from the larger lesion. And that came as suggestive of granulomatous lymphadenitis, possibly tuberculous. And she was started on standard ATT. But the patient started worsening even after starting the anti-tuberculous treatment. So he has decided to undergo ERCP and biliary stenting. So he thought the biliary obstruction is causing the worsening of problem. So the initial stenting was done. One stent was put. Patient continued on standard ATT for next 6 months. In between, he replaced the stent after 3 months. But patient continued to have recurrent symptoms, and hence he decided to put another stent in CBD. Subsequently, she underwent 2 more sessions of bile duct stenting, and ATT continued for next 12 months, but patient's general conditions started worsening. So the patient was brought to our department. So before going to further discussion, I wanted to get the opinion of the gastro surgeons. Can we proceed straight away with just a biopsy or FNAC or a CT guided FNA from the lesion and saying that it is tuberculous lymphadenitis, and patient was put on ATT, but there was worsening on ATT. Do we require any further biopsy or further investigations to proceed further, or shall we consider surgical exploration?
We start with Paari.
Yeah, Prathapan, yeah. One thing I believe is, and I've been practicing for the last at least 20 years is, I mean, any lymph node, even if it is granulomatous on FNAC, I don't take it for granted as tuberculosis. So it's been so many times that it turned out to be not tuberculosis. So I guess more investigation is in order, at least a CT of the chest, and and other investigations to make sure it is just tuberculosis and not sarcoidosis, and other necrotic infections which we see with fungus and hematological malignancies. I think minimum they should have done a CT of the chest, and if possible, if there was any other lesion there, they should have taken a good chunk of it was FNAC was done, right? Not biopsy.
No, FNAC only. CT guided
FNAC, in my opinion, is inadequate to start ATT. So I think a good biopsy and a minimum workup of CT chest and a possible calcium, ACE levels and all should have been done. So I wouldn't start a ATT just on the basis of FNAC, even if I see granulomatous lymph nodes.
Dr. Shankar.
Yeah. Prathapan, I want to know what was the LFT values, what was the imaging which warranted a stenting, because it's basically a lymph node lesion. And lymph node lesions to produce cholangitis is very unlikely. So what was the, say, MRCP or, because this the patient's fever must be relaxed. So there is no need to immediately jump into the conclusion that the patient had cholangitis. So I want to know about the liver function test. Was any
at the time of admission, initial evaluation, she was having around
before
5.8, total bilirubin of 5.8 and conjugated bilirubin of 3.
Okay, but was the patient really in cholangitis which warranted a ERCP and stenting?
This is what I got from the discharge summary of the gastroenterologist. But
okay.
I will come to the workup done and the evaluation done after that. So
and you said that after starting ATT, patient was worsening.
Yeah, she was worsening.
Is it related to the ATT itself? Because ATT itself can produce liver problems.
The worsening was not related to the drug-induced liver dysfunction because they continued ATT even with that worsening of symptoms. So I don't think that was due to the anti-tuberculous treatment per se.
No. What exactly was the worsening symptoms you are trying to tell? What was the symptom?
She continued to have pain, fever, intermittent worsening of jaundice and all.
Okay.
So that is why they decided to do a stenting the first time.
Okay.
So even after stenting, she continued to have worsening. Even on ATT, she continued to worsen her fever. And subsequently, they decided the lumen size may not be adequate. So they decided to do a few more stenting in a span of 1 year. So the patient came to surgical gastroenterology department after 18 months of initial treatment, initial evaluation and work.
Was any brushings done or biopsy done during ERCP?
That was negative for any malignancy or any other thing. That was written in that initial ERCP. Dr.Ilango.
Okay.
Yeah, I agree with Paari. It was too early to jump to conclusion and start ATT. Yeah, at this point of time, I would further investigate only with imaging to find out and confirm diagnosis of tuberculosis and whether it is the right way to proceed. Apart from that, I really have no clue.
Okay. So
my question to Prathapan is, was the patient referred to you by the treating gastroenterologist?
No.
The patient came on her own.
I will tell you the story. That patient is coming from my home place, but they don't know Dr. Prathapan. But they came through another person in nearby Calicut, and finally they were that patient was my sister's classmate. So that was the interesting story of that. So I just put this Benjamin classification.
And I have a couple more questions if you don't mind. The second question is, when you talk in terms of patient worsening, again, it's all to do with the worsening biliary obstruction, worsening cholangitis, worsening liver function test.
Yes.
LFT is worsening basically, not the patient per se.
LFT worsen, and when we give antibiotic, she improves. So there is not persistent improvement on treatment, even on ATT, even on stenting, even on antibiotic. That the treatment is not completely curing her problem. That was the issue. So I just put a slide on Benjamin classification. I wanted to know the opinion. Which classification this obstruction belongs? Is it a type 3 or a something related? I will come to it later.
I would have been glad if you would have put up some image by now.
Okay. So at the time of first visit in our unit, patient was emaciated with a weight of 23 kilogram. Her daughter at that time, studying in 6th standard, was weighing 40 kg. So she was only 23 kilogram. She was febrile, pale, and there was mild icterus, but there was no generalized lymph node enlargement, no signs of pedal edema, or no signs of liver failure. Abdominal examination revealed a firm palpable liver with palpable GB. There's no splenomegaly, no clinically demonstrable free fluid, and there was no evidence of any umbilical nodule, pelvic deposits, or any left supraclavicular lymph node enlargement. So we did an investigation. Hemoglobin, basically it was 9.2 gram per deciliter. There was an increase in total count. Platelet count was very high. It was 7,47,000. INR was 1.1. CRP was again raised. Total bilirubin were conjugated. It is only mild rise, 2.1 versus 1.1. And SGOT and PT also in the range of 90 and 115. Alkaline phosphatase was elevated, 370 international unit. Total protein was low, albumin was low, viral markers were negative. The tumor markers CEA, CA19 and both were negative.
Now, if I interrupt for
So
a
you
minute,
can see the plain X-ray of abdomen which was taken by our unit that showed 4 stents in
if I
the
can interrupt you
abdomen.
at this juncture,
For first time,
is
I'm seeing 4 stents in the
multiple stent
in a
business.
single biliary tract, like it's a
Multiple
large
stent
stents.
business.
And surprisingly, all were fitting in the bile duct without any issue. But patient is having symptoms. That was the basic problem. If we have space for 4 stents, he should not worsen. As per se, even the cholangitis should disappear. So this was the CT. It was taken after stenting.
Prathapan, can you hear us?
And you can see the plain CT showing some minimal.
Patta sir, I think he is not able to hear us.
Dilated bile duct, mainly towards the right side of liver. That's the right lobe of liver is affected mainly, and there was suspicion
Prathapan,
of
can
a
you hear
mass
me?
lesion in the hilum. I will come to its contrast.
Prathapan, can you hear me?
The opinion of gastro surgeons regarding the CTs. These were the CTs available at the time of admission in my department. I didn't repeat the CT because she was already financially very pathetic. So I didn't think of any further investigation other than re-evaluating the available investigations and what possible we can do. That was my status at that time. So this was the initial CT, not initial CT taken after stenting. They were looking for what is the reason for worsening. So interestingly, the liver shows some evidence of some cholangiotic abscess. I will come to the contrast film. You can see this film. So these are the film available with the patient at the time of admission in our unit. Comments from the professors.
Prathapan, can you hear us?
Start from Ilango.
Prathapan, can you hear us?
Dr. Ilango.
Prathapan, can you hear us?
I'm not hearing.
Yeah. Prathapan.
Ilango, you are not audible.
Yeah. Patta sir, are you able to hear me?
Yeah, we all hear each other, not Prathapan.
Yeah, the problem is Prathapan's speaker.
I can't hear.
Increase the volume. The speaker volume is down, I guess.
Okay, I didn't hear most of your discussion. Just repeat it.
Yeah, Patta sir had a question for you. Can you, sir, Patta sir? We've been tracking.
No, can you hear me, Prathapan, now? Can you? You have to change the audio settings. Hello? Can you hear?
Yes.
Can you hear me?
Yes, I can.
Yeah, see, actually, when you are putting up that plain X-ray picture and you could see multiple stents, you know, I've seen actually while I was working in Hyderabad, there's a famous gastro institute nearby where they put 4, 5, 6 stents. Actually, those are used when there was a benign biliary stricture, and they used to keep the stricture open for quite a while, and that was the reason that used to be done. No, so I was wondering because those many stents, is what could be the thing on the mind of the physicians who are treating. There's a hello, Prathapan, can you hear?
Yeah, I can hear.
Okay, now that is what I was about to ask, but Ilango to take over. Yeah, Ilango. Hello?
Ilango, you are not audible.
On the coronal section, I'm able to see intrahepatic biliary radical dilatation, posterior sector. Anterior sector does not show anything. Yeah, I think you can see the anterior sectoral duct also.
Is it the anterior sectoral duct or the posterior sectoral duct? That was my confusion.
I think this
I didn't get the report.
6.
Yeah.
This is 6, and this is certainly the anterior sectoral duct. So it's like this. Whenever we see a cholangiogram, put your hand like this. It's just a mirror on the image. The one vertical is the thumb represents 5, 8, 6, and 7. So 5, 6, 7, and 8. So it splits like this. So that's a classical teaching. I don't know how to show it the other way around. It should be like this: 5, 6, 7, and 8. So if you keep your fingers like this, anybody can learn it like that. So this is the anterior sectoral duct. But apart from that, I'm very here. It's very difficult to give an opinion on static image.
Ilango, why should the ducts be dilated in spite of having 4 stents?
That's a good question. I don't think so. The collapse was, maybe the ducts themselves were obstructed by the tubes placed.
Very unlikely.
I can't explain that.
Because
that was the main concern for me presenting this case. Because even with 4 stents, you are having a dilated duct. So the cholangiogram will show some abnormality. No? When we do ERCP, we do cholangiogram. And that will show the abnormalities in the intrahepatic biliary radicals. So why we didn't pick that? That was my concern. I didn't tell anything about that.
So now, Prathapan,
yeah.
when you have stents placed for 18 months, that itself can produce problems. So I don't know how frequently these stents were changed or exchanged.
But the liver is normal on one half. The right half is abnormal. Left half is almost normal.
Absolutely normal.
So, that's what, because when we see the X-ray, you can see it is placed on either side. It is going to the right and going to the left. There is no confusion because the right and left ducts are actually drained by these stents. So when we look at the CT images, we are having some concern because the liver shows some evidence of localized biliary dilatation. At least as some sectoral ducts are only dilated with some cholangiotic abscess in the liver. Okay.
Intrahepatic choledochal cyst type is a possibility where they may not collapse in case. One of the possibilities. Yeah, Paari.
Prathapan, yeah, one thing is it could be a choledochal cyst, as Patta sir was mentioning. We need to have a good cholangiogram images. And other thing, it could be, I don't know, we need to have a good cholangiogram to see. Maybe there are multiple segmental strictures like PSC, in which case, you can have persisting intrahepatic biliary dilatation. And then there is evidence of cholangiotic abscesses. And we can't be sure whether there's any infiltrative disorder also going on. And I'm also able to see some soft tissue lesion anterior to the CBD. I don't know, because with this one snapshot, I can see that there is some soft tissue lesion anterior to CBD. We need to have better images to comment on that. So
these were the images I got. Because
I know.
The date of that, you just look at the date of that CT, it's long back. Because at that time, many of these cholangiogram or the US was not available in most of the centers.
Yeah, I probably would go for one CMRI and ask them to reconstruct the cholangiogram also.
Prathapan, at this stage, I would prefer to remove all the stents because I don't want those stents to be there, and I do not know whether the stent is producing problems. So the first thing I will do is I'll remove all the stents, and then if the patient is reasonably okay, I'll just treat with antibiotics and give some time, say for 2 weeks or 4 weeks, and then do a re-imaging, preferably a cholangiogram.
Yeah,
MRC.
So that's
I have Prathapan, I have a question.
Yes, sir.
So suppose whenever we stent a patient for a biliary obstruction, which is not so very severe, we remove a stent, put another stent generally.
Yeah, usually.
But what
if
is the
there is
philosophy of
suspicion of
putting one after the other? Is it one stent blocked, another stent put in, that blocked, another stent put in, is not removed? I mean, I don't know. What is the philosophy of putting multiple stents in a patient?
So this is the method they use for biliary strictures, because when we keep multiple stents, that will remain dilated. It won't.
So the question is, why was it used when there was no diagnosis established, or were they convinced that the ductal obstruction was secondary to the node? I presume the soft tissue mass anterior to the CBD is that large node. It was a 4 centimeter node, isn't it?
Yeah. Okay. So there were many cases. That is why this case is presented. Okay.
Yeah,
So this was the opinion I got. So they did an MRI. They came with actually a MRI. So this MRI was taken 4 months after the CT, which we showed. So the MRI showed IHBRD mainly on the right side. There was a mass of size around 3.6 into 3.2, hyperintense on T2 weighted image, hypointense on T1 weighted image, with multiple SOL in right lobe, possibly cholangiotic abscess, distended GB with thickened wall and adherent slut, multiple biliary stents in CBD, and no biliary anomalies. That was the thing which I was carefully looking for. They did not identify any biliary anomaly. That's the reason they asked whether there is a localized Caroli or the localized choledochal cyst, intrahepatic choledochal cyst, or some other disease. There were no stones as such in the bile duct, because we have seen many recurrent pyogenic cholangitis patients presenting with isolated involvement of liver lobes. So that there were no stones. So these are the MR picture. So you can see the MR picture. Just comment on MR.
Ilango?
Sir, I'll take some time. I usually take time to read the image.
Prathapan, what was the HIV status of the patient?
Negative. I have mentioned all markers were negative.
So all I can see is there is I think the image, the MRCP image is taken from the posterior aspect. So I think the right is much more enlarged bile ducts than the left. I can't see the proper CBD on the MRCPs. Oh, it's here, an anterior one, it's on the lower side. Okay. So it's dilated and there is a soft tissue mass. Apart from that, I'm not able to make out anything. A few cholangolytic abscesses on the right lobe.
See
the mass is present on the anterior aspect of the CBD.
The junction of right and left hepatic is not made out properly. It looks like, you know, the separated.
So this is from the posterior image, sir.
That is another image. Okay, you can. This image will give you further.
The left hepatic duct.
You continue.
The right is joining the cystic duct.
Is it the right is joining the cystic duct? Or vice versa, cystic duct joining the right. I don't know. They have not mentioned anything in the MRCP.
Okay.
Ilango, the straight line, thin line which is pointed with CBD, is that a stent actually?
It's a CBD.
Is that a stent or a CBD? The straight line from the left duct lower down on pencil line. Is that a stent or is it CBD?
It's almost like the stent.
Yeah, because it's so thin, pencil thin, and actually see That system looks different from the biliary, the gallbladder and the right system.
It will show only stents, sir, because there is no fluid to give the MRCP image.
Right, okay.
Yeah, there is
So-
outfield. There is an isolated system on right side.
One
Yes.
thing can I?
But-
Yeah.
Yeah, Paari.
So obviously, there is dilatation of the right ducts and left duct. But one thing I learned over years is never comment very dogmatically on a static image of MRCP. This is very fallacious.
Prathapan,
Yes.
can you just go back to the X-ray images once again?
Yeah, unless we get to see the live images, crawl them, it's very
Okay.
easy to
Can you-
mistake the MRCP.
Can you go back to the MS? I think the stents is not placed in the right duct at all. You can go back to the MRCP. Full next one. I think both the stents are placed in the left system. I think the stent is placed on.
No, there are 4 of them, Ilango, not just 2. 4 stents.
I think the right duct is not fully drained, sir. Looking at the orientation of both the stents placed, even all the 4 stents, I think the left ducts and the CVD were completely drained. The right duct, I think they have not even cannulated.
My worry is, are the ducts communicating at all, the right and the left?
No, it doesn't look like, sir, at least on this image.
They look so different, yeah.
Sankar.
Yeah, I agree with Paari. We need to rotate the images in the console and see.
We didn't have
With
that.
static, yeah,
CD
with
was
static.
Yeah. CD
Very
was not
difficult.
available. I got only
Now,
this.
Shankar, will you take this answer from a student when you are questioning a student that, sir, I want to see a thing.
Yes, sir.
No,
Yes,
this
sir.
is the picture you have given. This is what you have to say.
No, I will just, if the candidate say, I'll agree only. If it's difficult for me, it should be difficult for the student also. What is that? See, static images, MRCP, we cannot tell. We have to rotate the images on both the directions, craniocaudally, then only we can comment about it. Otherwise, there will be overlap and we can't comment about it.
Yeah.
Okay, so we'll move further. So I repeated only one ultrasound. That's the one which I did in my department. All the investigations were available with the patient. So the MRCP images, I was thinking of some biliary abnormalities. That is why I was stressing on that biliary anomalies. I do agree that there is no complete drainage of the liver by these stents, even though they placed 4 stents. Some of the liver, some part of liver was not drained at all. So the ultrasound showed coarse echo texture of liver with peripheral specks of hyperechogenicity. There is hypoechoic lesion with internal echoes in hepatoduodenal ligament. There was, again, they were saying it is suggestive of lymph node in the hepatoduodenal ligament, possibly tuberculosis. There was evidence of dilated biliary radicals, predominantly in the right lobe, with dilated CBD and adherent sludge and stent. And gallbladder was again distended with the sludge.
Now, Prathapan, if I can ask you here, I mean, what is the wisdom of doing an ultrasound here? I mean, what exactly you wanted to prove or disprove?
Because I wanted to know whether both the system, the right and left systems, are affected or not. Second thing, whether there is metastasis or some other disease. Are we missing some other disease? Can be some tumors or something. So if there is multiple foci of lesions which are not seen in the previous images, we can think of some other diseases as well, because we were all carried away by the initial report. We were all thinking of tuberculosis because she was treated as tuberculosis.
No, but
so that is the.
How did ultrasound make your life any better now?
No, sir, because we have to pay for all images. We work in a government sector. We can't have that much.
That is not a defensive point.
No.
Shankar,
I didn't do
candidate says go for the ultrasound. Would you agree?
We have to do. We have to do MRCP. MRCP was not freely available at that time in our department, but they came with an MRCP. One imaging was available with around 3 months back. They did that MRI. So that was showing either the isolated problem in the right lobe of liver, multiple stents draining rest of the liver. So there was some foci of infection in one part of liver, and we didn't know what exactly happened. So in this juncture, how to proceed?
Prathapan,
Yes.
as I told you already, the stents are not working. We have to remove that stents. And if the patient is having cholangitis, I would prefer to place a nasobiliary drain and give some wash so that I can take care of the cholangiolitic abscesses. And I will also keep in mind rare diagnosis like melioidosis, etc. I'll get some specimen for microbiology, cultures.
Blood culture we did, that was not showing any bacteria. There was no evidence of any bacteria. And the TB PCR was also not positive.
Your
TB
CRP was high, your total count was elevated. Those are good enough markers for inflammation. Nowadays we always don't get fever.
Continued inflammation. There is continued inflammation.
Are we still following the Charcot triad, Shankar sir? You are in academics, Prathapan. Are we still telling the students that the classical Charcot triad, or is it just theory?
No. We have to tell them there is Charcot's triad, but all components need not be there to diagnose cholangitis. That is what we tell them. So no, don't look for the, don't wait for all the three components to appear before you diagnose cholangitis. So
no, to answer Ilango's question, I'm a great believer of Charcot's triad as well as Reynolds pentad also, because they are not just for academic purposes. In clinical practice, it's very important. Otherwise, we have to emphasize to students the importance of diagnosing cholangitis. Cholangitis is an impending time bomb. So it has to be treated with the contempt it deserves. So one cannot sleep over a patient with cholangitis.
Okay, now how to proceed further? We'll have what is Ilango's plan? What is Paari's plan? What is Shankar's plan? Says take away stents and watch. Yeah, Ilango and Paari.
No, sir. I told sir, remove the stent and put a nasobiliary drain and get some specimen for culture. We can actively give some washings of the cholangiolitic abscesses. So even you can combine with a PTBD for the dilated segment. So all the options should be considered, but the stent should come out first. Yeah.
Ilango?
So my first step would be is that these are small cholangiolitic abscesses. I start them on broad spectrum antibiotics, wait for 48 hours. They already have the stent. I will exchange the stent and probably see whether the right system can be cannulated. That I think we have to make a deliberate attempt for that. And I will wait for 48 hours. The timeline is I start the antibiotics, remove the stents, wait for 48 hours, reattempt the ERCP. By the time I need to get some control. If the abscesses increase in size or the blood cultures become positive, those have to be addressed. We may have to change the antibiotics or drain the abscesses with percutaneous drainage. But apart from that, at this point of time, this is what I would do and look at the progress.
Paari?
Ilango, I have a question to Ilango. So I have repeated the ultrasound 18 months after the initial investigations, which showed a lesion suggestive of a lymph node in the hepatoduodenal ligament. The size of the lymph node was persisting even after. Yeah, it was not changed. So why didn't think of any other? This was the thought process I had, because there was a persisting lymph node or 18 months. Still, we are not thinking of any alternate diagnosis. That is what.
I agree with you, but I have no clues for that. But this is the first step I would do. Paari?
One thing is, in my mind, I feel there is no significant biliary obstruction because symptoms have not become better with stents. I agree with Shankar sir, I'll remove all the stents. 2, I don't think there is tuberculosis because the nodes don't look like tubercular nodes, typical tubercular nodes on the whatever imaging you are given. So I'll remove the stents, I'll take good culture, The ultrasound had shown good abscess which can be aspirated for culture. I'll take a abscess for culture, then start antibiotic. I will not start antibiotic straight away because I'm sure for over the last 18 months he has been receiving antibiotic after antibiotic. So my antibiotic is going to be properly focused antibiotic. I want a good culture. I won't even hesitate to take a biopsy, 2 specimens even for culture, one for biopsy and one for culture of the liver. Having said that, most important thing is to diagnose what is the primary problem. For that, we need a good imaging and a US guided biopsy. That's what I will do. So remove the stent, wait for some culture, and then start antibiotic, and try and get a good imaging and try and get a US guided biopsy from the lesion in the anterior to the CBD.
Yeah, my take, Prathapan, as most of the specialists feel, I remove the standard. For all you know, she may just become better.
No, I also agree, but I had a patient in whom they removed the stent within 48 hours, patient succumbed, died. Some patients can worsen like anything when they have cholangitis or some issue which are managed by stents. I think there are patients. I lost one patient. Immediately after removing the stent, patient went in for sepsis and
removing stents because the obstruction is not getting relieved. If there's a lymph node blocking the bile duct, a stent has to relieve it, and the stent is.
I have.
See, so stent is obstructing now. The stents, whatever, obstructing the biliary system. So first thing we do is remove the stent, see how the patient responds, because it's very likely the patient may respond just by removal of stent, not putting any nasogastric or nasobiliary or even percutaneous, whatever. For all you know, the stents may be the pathology and they may be the removal, may be the treatment.
So,
and then wait and watch, then think of further imaging if necessary.
Okay. So because of inexperience, I behaved like a typical surgeon. So I started this patient on nutritional support, UDC and antibiotic. The patient was not improving within 1 week. So I thought of doing an open drainage because I didn't have ERCP support at that time in our institute. So we have to send them outside for getting this ERCP done. But I was thinking of a hepatico-jejunostomy because I have some other thing in mind. I thought of some recurrent pyogenic cholangitis or isolated liver involvement, which cannot be cured by the ERCP or repeat stenting. So any difference of opinion, I think there will be, because as surgeons, we may take earlier decisions than the physicians.
No, I think that's like jumping into fire. We don't know what it is, and then you have a big mass in front of the CBD. I'm not even sure what that mass is, whether CBD will be approachable or not, and whether if we treat the mass, then probably the problem is over, because it all started with some lymph node or whatever mass in front of the CBD that has to be dealt with. So what is required is histopathology of the mass lesion. So probably I would have just gone for the histopathology mass.
Required. Okay. So
the outright surgery is blasphemy, not acceptable at all.
Yes. So that the lesion in that hepatoduodenal ligament was persisting for 1.5 years, but without much increase in size. So aggressive malignant process is out of question, because there is nothing to suggest cholangitic carcinoma or some other malignant tumors in the hepatoduodenal ligament.
It could be hematological malignancy. It could be hematological malignancy, in which case the treatment is totally different.
Okay,
you can have fever, you can have jaundice, you can have, you can have granulomatous in histopathology. You can have everything with hematological malignancy.
So I'll come in support of Prathapan. So what do you do in a situation you don't have an ERCPist, you don't have a EUS? Say you are working in a mission hospital or in a hospital in North India or Northeast India, where you don't have access to these things. Would you do a laparotomy or not? Shankar sir?
Not acceptable.
No, I'm just asking. I'm playing the devil's.
I don't have a CT scan. I don't have an MRI scanner. So what will I do? See.
No, sir. No. I will tell you what exactly happened. This patient
What was your thought
worsening.
process?
So I didn't think of tuberculosis at all because 18 months of ATT, I wanted to change the diagnosis, clinical diagnosis, because repeating FNAC will not help you. Repeating US was not available in 2010. US was not available in Calicut.
But FNAC was available. You could have done the FNAC.
No, already they did an FNAC. They have started ATT just based on the FNAC report saying. We could have repeated FNAC. It may show some other other histopathology.
The lesion is large enough for you to do a
sarcoidosis.
core biopsy.
You just need to give some. If it was sarcoidosis, you just had to start him on steroids. It could be, you know.
Okay.
Not,
so
okay, I'm curious now.
We have to stop because I started operating this patient. I started operating this patient.
Hey, Shankar has something to say.
Prathapan.
Yes.
Yeah. I mean, obviously, surgery cannot compensate for lack of expertise, investigations, expertise and all. But the surgeon who is facing the situation should take the call. I don't want to comment on that. Now, did you think the possibility of, as Paari was telling, sarcoidosis and other diseases like IgG4 cholangiopathy? I do not know.
IgG4 was not done. EUS was not available.
and
I didn't think of, because IgG4 disease we have seen later, because it was very popular in 2013-14 time. At that time, we were thinking of the other diagnosis, tuberculosis. Then there was something called inflammatory tumors, inflammatory
cholangiopathy.
Masquerade, malignant masquerade. Yeah.
Masquerade. This patient, actually, the patient's clinical condition was not very happy, because the patient was worsening because her weight was only 23. She was not improving. And repeating investigations, repeating ERCP, repeating stenting, etc. I thought that may further worsen her financial as well as health situation. So that was the reason for planning surgery. So I opened the abdomen. There was a mass in the proximal bile duct that is actually attached to the proximal bile duct, that was compressing the common bile duct. And there were 4 stents in the CBD. Mass was not infiltrating the adjacent vessels or bowel. So we could remove the mass. The right lobe showed multiple organized cholangitic abscess. Lower CBD was normal. So, this was the, I don't know whether it will. This is the distended GB. GB was there. If there is time, I will continue with this.
Yeah,
otherwise, I will just skip.
Continue, but you had the luxury of harmony scalpel.
Yeah.
That was the old variety of harmony scalpel. Now this is not available. The wave probe. No, this is not complete surgery. I wanted to show the area of involvement. I didn't have full video of this surgery because my president did not take it fully. So I got some snippets of that surgery. So there was a mass lesion in the proximal bile duct. Distal bile duct was seeming normal. The duodenum, that is the area of lower part, CBD, duodenum. And you can see the mass. That was not looking like a lymph node. It was not looking like a typical lymph node. It was something different. A flush, not fleshy, very firm mass. Because in during biliary surgery, we see lymph nodes in the hepatoduodenal ligament. They all occupy a place in the posterior or lateral aspects of the bile duct rather than the anterior aspect. Anterior aspect, we see only the cystic lymph node of Lund and other small lymph nodes. But predominantly, they occupy on the lateral and the posterior aspect. This was occupying the front of the bile duct. It was very looking more firmer than the usual lymph node. I didn't see any pus on pressing that tumor. I didn't see. But my thought process was again the previous diagnosis of tuberculous lymph node. So I didn't think of radical surgery and all. I was just thinking of just to remove the lesion and do a good biliary drainage. That was my aim when I planned this surgery.
See, anyone from the audience to make a comment, please raise your hand, unmute and ask your question. Anybody?
So interestingly, when I proceeded further, this patient had a biliary anomaly that was picked up by Dr.Ilango. The right posterior sectoral and the left duct was forming the common hepatic duct. The anterior sectoral duct was separate. That was a very unusual situation which we didn't come across. And the gallbladder, the cystic duct was attached to the aberrant bile duct. And the opening of this aberrant bile duct was completely obstructed by the stents in the CBD. That was the reason for worsening and persistence of symptom. And the lymph nodes in the exterior lower part, there were lymph nodes. That was just the usual inflammatory lymph node. This was the operating findings which I got or I derived by seeing the structures. So these are the hepatic duct. The lesion is seen on that area. We cut the one part of the bile duct. Actually, that is a common hepatic duct area.
No, we don't see any images. We're not seeing any images. Are you sharing the images?
Yeah, the video is running.
Video is running. So when I cut the common hepatic duct, the part of gallbladder and the tumor was attached to another structure. So actually the lesion was predominantly arising from the aberrant duct, which is draining the right anterior sector, and that was compressing the common hepatic duct, which is formed by the posterior sector duct and the left hepatic duct. So the tumor bearing segment of liver or the bile duct was not at all drained. So Dr. Ilango was partly correct because the right anterior sector duct was not drained by the stents. So that was the reason for persistence of symptoms and development of cholangiotic abscess confined to that area. Now you can see that duct. So there is a duct coming from that area. You can see the cut end of the common hepatic duct. Another duct is in there. So this patient had an isolated right anterior system, which was not drained by the stents. So that was the reason for persistence of symptoms. You can see the cut end on that area. The cystic duct was attached to that anterior sector duct with the tumor in that segment, in that bile duct, which was compressing the common hepatic. You can see the ducts, separate ducts. Ilango, is it the anterior duct or the posterior duct?
This is probably the anterior duct. If you look at the image, the curve is on the posterior duct is joining the left hepatic duct.
So this was the so I lost that. So you can see two ducts. One was totally isolated from the rest of the system. So this was the basic issue for non improvement in cholangitis or persistence of inflammation or cholangitis. So you can see the right, the common hepatic duct, and you can see the isolated duct on the right side. That was actually cannulate was going anteriorly. So this was the, and I took the biopsy from the liver lesion also. Okay.
And you should send this for culture also.
Yeah,
Liver
bile culture
liver
was
tissue also.
showed E. coli was
No, here the bile culture is not the right
stem culture
thing, because if you got stents there, it's going to have, fallacious, a lot of colonizing organisms. Here you should send the liver tissue for culture.
Culture, okay. So I did a Roux-en-Y hepaticojejunostomy. The right anterior sectoral duct and common hepatic duct separately anastomosed to the jejunal limb, and biopsy from the liver lesion in the anterior sector. So I completed the surgery. The next question, whether to do an isolated anastomosis or a ductoplasty and making it a common hepaticojejunostomy. In this case, transplant surgeons.
Yeah, they're too widely apart.
Yeah.
I will do two separate hepaticojejunostomies.
Yes.
They're not close by.
Okay, this is for the students. When there is a gap between two ducts, I think that will be better. So these are the two ducts. I'm not showing the videos. You can see anterior duct separate and the common hepatic duct separate. We did separate anastomosis. These are the two separate anastomosis. So these are the images which we got. And this was the thing which it was a pictorial representation. You can see the right anterior sector, the segment 8 and 5 was predominantly affected. The tumor was involving the anterior sectoral duct, which was separately joining the common hepatic duct well below the confluence. And we did a separate hepaticojejunostomy. So this is the biliary anomaly we had. But in this case, we have an interesting thing. The cystic duct is joining the anterior sectoral duct. That is not described as a separate entity. We know these are the biliary anomalies described. You just look, all the gallbladder entry are onto the posterior sectoral duct. It is not onto the anterior sectoral duct. So there is a classification for the entry of cystic duct and aberrant posterior sectoral duct. That is the Hisatsugu's classification. In that, they consider only the posterior sectoral duct with the cystic duct, or entry of posterior sectoral duct and cystic duct into the common hepatic duct. So I'm not going into the details. So the final HPR is they made a change. There is a tumor which disposed in short, vesicular and vague storiform pattern, variable collagenous stroma, spindle type of tumor cells with oval to elongated nuclei, minimal nuclear pleomorphism, inconspicuous nucleoli, pale eosinophilic cytoplasm, dense inflammatory infiltrate comprising predominantly of mature plasma cells, and occasional glands lined by biliary type of columnar epithelium. They are all benign glands. And immunohistochemistry they did, it was reactive for vimentin, SMA, it was negative for cytokeratin, CD34, CD117. At that time, the DOG1 and ALK1 was not available. They didn't do it. So this was the immunohistochemistry and this thing. So final report came as inflammatory myofibroblast tumor of the bile duct. Supposed to be a very rare disease on the bile duct, because we see intra-abdominal inflammatory myofibroblast tumors. Most commonly they are seen in the lung, first described in lung, but we see in the abdomen, in GIT, genitourinary system. But bile duct is a very rare site for an inflammatory myofibroblast tumor. The case was reported only in less than 10 cases so far. In this case, the margins of resection were free. GP was showing chronic cholecystitis, lymph nodes showing reactive hyperplasia, and liver lesion consistent with chronic cholangiotic abscess. So this inflammatory myofibroblast tumor. Now, any further discussion need?
Obviously, recurrence should be quite high.
Okay. So this patient we operated in 2010. Now it is 2021. I have seen that patient. She got a job in government sector and she gained weight. She is now 53 kg. I think there is no recurrence. Inflammatory myofibroblast tumor is not. It's not. Recurrence is seen in around 20% of in literature. So inflammatory myofibroblast tumor is not a very rare tumor, but inflammatory myofibroblast tumor of bile duct is a it's very rare. So it's an intermediate grade, rarely metastasizing lesion of mesenchymal origin, commonly seen in abdomen, but biliary tumor is very rare. It's an uncommon cause of obstructive jaundice, and patient will present with non-specific symptoms. They can have painless jaundice, unintentional weight loss, and it may mimic cholangiocarcinoma clinically as well as radiologically. Here it was mimicking a tuberculous node because cholangiocarcinomas usually they have the sclerosing type of sclerosed type of growth pattern in that area. Usually we don't get a mass like cholangiocarcinoma in the proximal CHD or proximal CBD level. There is a strong association of biliary IMP with autoimmune pancreatitis. This described, so that as Paari was telling, we did do a IgG4. There are three types of growth pattern described. One is the cellular compact spindle cell pattern like this. We have other types like hypocellular, densely collagenous pattern with few spindle cells and predominantly inflammatory cells. And there is a third pattern with loose myxoid stroma, prominent vascular pattern. You may see necrosis and mitotic figures, but atypical mitosis is very rare or it's practically absent in patients with inflammatory myofibroblast tumor. So the differential diagnosis can be GIST. GIST is not usually seen in the bile duct. It may be seen in the distal bile duct or the ampullary region. Leiomyoma, leiomyosarcoma, these are all possible lesions in that site. It can be inflammatory fibroid polyp, or it can be schwannoma, or it can be fibromatosis. So you can differentiate these tumors by immunohistochemistry. So GIST will be CD117 positive, but IMT CD117 will be negative. Around 50% of patients will have ALK1 positivity. We have not done in our department. So the treatment of inflammatory myofibroblast tumor is surgical excision. You can give anti-inflammatory drugs like selective COX-2 inhibitor. It may have inhibitory effect on angiogenesis and cell proliferation by induction of fibroblast apoptosis. You can consider chemoradiotherapy in case of non-resectable lesions. If the patient is having ALK1 positivity, you can treat with crizotinib. This is required only in non-resectable or tumor which are debulked as a part of surgery. The local recurrence is seen in around 10 to 25%, so follow-up is recommended. And metastasis will be seen in less than 5% of cases. So that ends the first case. So, yes.
Prathapan, fantastic case, very well done surgery. But having said that, in this case, what I feel was the ends did not justify the means. So here, irrespective of how the case went and the patient doing well, right now in this 2021, if the same case comes,
we won't do like that. No, in 2015, if this case has come, we won't do like this. We did it in 2010.
Right.
Because I have 11 years follow-up of this patient. So when Patta sir asked me to start this clinical meeting, I thought of this case first because this actually had a lot of things as a surgeon, as a consultant when working as a single man in a department. So I was working as a single man department for long. And this case, to whom we can have discussion for further treatment and all, it was a real issue. So finally, when I completed surgery, I was very happy when we got the final HPR saying it is a tumor rather than a lymph node alone. I think occasionally we may escape because.
Yeah, comments from Ilango and Shankar before we wind up.
Prathapan, nice, very nice case, and at least I learned a lot of points in this case, and it's really a rare case. And now, only thing is, I want to say is how do you differentiate between this and fibromatosis, because both resembles almost same. This fibroblastic tumor, inflammatory fibroblastic tumor from fibromatosis. Because immunohistochemistry markers are almost the same.
Almost
except that the fibromatosis, if you make a diagnosis of fibromatosis, recurrence rate is very high. That's why when you ask what is the follow-up, I told about recurrence. Probably the clinical pattern may be differentiate between these two entities. Histologically and immunohistochemistry wise, both might look similar.
I do agree, because the markers are all the same.
But very nice case presentation.
Ilango?
Prathapan, nice case. It was a complete learning from me. What I could do, I mean, from my head, all I could think of was this was something odd that does not fit into the regular one. So the clue was in the anatomy. Apart from that, without the current devices, I would have followed the same way. But I think I probably would have attempted a core biopsy, CT guided core biopsy. That was the only thing that I had in my mind. A wonderful case. Thank you. Great learning.
Biopsy will help you to plan the proper surgery. If that is a tumor, you could have thought of some radical surgeries and all. I think you're seeing that surgery, I was a bit unhappy because final report came as inflammatory tumor. Obviously, the margins were negative. When we were having multiple stents in the bile duct, the thickening will be there throughout the bile duct. So it's very difficult to differentiate whether it is tumor or the thickening due to the inflammation and all. So, thanks.
But another interesting point is both the MRCP as well as the multiple ERCPs then have not demonstrated the biliary anomaly. That's also
actually I wanted to highlight that rather than the tumor, because tumor is a pathologist concern, but the biliary anomalies are very important when we plan any biliary surgery or any biliary treatment like stenting and all, because it can go, you can have problem even with stenting, simple stenting of a bile duct when you have biliary anomalies like this. I think a cholangiogram has to be read very properly before you do stenting or before you plan any surgery. That's a learning point in this case.
Yeah, Prathapan, all is well that ends well, actually. We should take it from there. But then if in the present scenario, with all the available facilities, would you done the same? Or would you again gone for some more imaging before? Because nowhere in the imaging you could see a proximal bile duct mass. Nowhere there was a suspicion. And actually the anatomy doesn't fit into any of the suggestive of proximal obstruction. Suppose if you have this patient, say similar patient again, because all the faculty felt that we have to remove the stent and then see, then wait. Of course, what you've done is right. You have preempted and went in surgery. That is the final solution anyway. But what would you not?
At this time, I think we will think of a proper imaging. We will repeat the imaging. We will do a repeat core biopsy from the lesion, and we may consider EUS or spyglass or some other thing which you can have. So we can actually visualize the bile duct. There are facilities available to visualize the entire bile duct. So we will not miss anything in the imaging or in the workup. I think in 2020, it is easy to manage this case, but it happened 10 years, 11 years ahead. That is what issue was.
Well done. Great case. Well presented. Thank you so much. Any audience, any questions before we close? Because, Prathapan has to go to another meeting. No questions. Thank you so much, Prathapan. And we'll wait for the next Saturday. Thank you so much. Thanks,
Thank you.
Paari. Thanks,
Thank you.
Ilango. Thanks, Shankar, for being here.
Thank you, sir. Thank you, everybody.
Thank you, sir. Thank you, sir. Good night.